Good morning, everyone, and welcome to today's meeting. I'm Juan Tello, head of the Less Alcohol Unit at the Department of Health Promotion in the World Health Organization headquarters here in Geneva. This webinar series was conceived to look or to zoom into the determinants that are driving acceptability, availability, and affordability of alcohol. This is the what, and the way we wanted to look at this is bringing together the most updated evidence that we have from academia, but at the same time look at what are the responses that civil society, sometimes even the governments or practitioners in general are implementing. We want to see all of that in order to inform policy options. We clearly will want to do that, bringing again around this series voices from civil society, from academia, and definitely frontline practitioners, and meaning governments in their all declinations, meaning national level or subnational levels. Not by chance, this is also the scope of this newly created unit called Less Alcohol, which is positioned at the interplay of many programmatic areas in the division of healthier population. The intention of the unit is to have a health promotion approach, a population-wise approach to the issues that are linked to the alcohol consumption and its determinants. But we do not work alone. We work jointly with many other units in this division, but also in other divisions in our office. Particularly, we are very much linked with the units of commercial determinants, or the unit looking at the violence, so the harm produced by the alcohol consumption, as well as safety and mobility, inequalities itself. But we also look, of course, at the colleagues that are working on the provision of services, brief interventions, and screening. The intention, in any case, is to overall for this division is to create healthier environments to make our choices or healthier choices easier. And with this introduction, let me thank also the presence of our Assistant Director General, Dr. Naoko Yamamoto, who will welcome all of you today. Dear Naoko.
Thank you, Juan. And dear participants, colleagues, and friends, and good morning, good afternoon, good evening. Thank you very much for joining this webinar. This is the first series of the monthly webinars on how we can address the burden that alcohol puts on people, families, and societies. I see many participants are still increasing from around the world. It confirms the interest and the need for tackling these issues collectively. I want to express my gratitude and also appreciation to the speakers, commentators, and panelists for their contribution by sharing their knowledge and making their expertise available. We know that alcohol consumption is a risk factor for over 200 health conditions, including communicable disease, non-communicable disease, maternal child health, perinatal conditions, violence, injuries, and self-harm. And the COVID-19 pandemic has made the situation worse in many societies. Most importantly, the consequences of alcohol consumption disproportionately affect people already facing social and economic challenges. This is going to be discussed in this webinar. If you want to make a difference for our societies, we need to promote healthier choices. Our intervention needs to be evidence-based, powerful, and continuous, culture-sensitive, and people-centered. We know what works at the population level. We need to reduce the acceptability, availability, and affordability of alcohol. We expect this to contribute achieving a target of 1 billion more people enjoying better health and well-being.
Hope to lay a bit of the groundwork for today's webinar, talking about alcohol use as a driver of socioeconomic health inequalities globally, and also addressing some alcohol control and cross-sectoral policies to reduce socioeconomic inequalities in health. The talk is structured along two main questions, the first of which being, how does alcohol use affect socioeconomic health inequalities? And the second one is, how can we reduce socioeconomic inequalities in alcohol attributable health burden? Starting with the first question, it is important to keep in mind that alcohol use is one of the most important risk factors or behavioral risk factors for burden of disease, accounting for about 5% of the total burden of disease globally. However, we know that this burden is very unequally distributed across socioeconomic groups. And one way to think about it is to look at alcohol-related mortality risks. So mortality from alcoholic liver cirrhosis or alcohol poisoning and such outcomes in different socioeconomic groups. And this is what I've done here in this meta-analysis. I have investigated the dose-response relationship between the level of socioeconomic deprivation that you see down here and the relative risk of dying from an alcohol-related cause of death for two indicators of socioeconomic status, education and income, and also for women, that is the solid line, and men, that is the dotted line. Okay, and what we see is as the level of socioeconomic deprivation increases, the risk of dying really increases. And how you can interpret this graph is that, for example, someone at the middle of the socioeconomic spectrum with regard to education, for women, there would be already a 3.5-fold risk of dying from an alcohol attributable cause of death compared to women with the lowest level of deprivation, or in other words, with the highest level of education. And for men, there would already be a 5-fold risk. So the takeaway from this graph is, first of all, there are vast socioeconomic inequalities for different indicators when it comes to alcohol attributable outcomes, in this case, mortality. Second, we see that a broad range of the socioeconomic spectrum is affected by that. It's not just a topic that concerns those at the very bottom of the socioeconomic spectrum. It really, the risk increases along the socioeconomic spectrum continuously. Now we also know that these relative inequalities are broader and wider than for all-cause mortality. We've done this comparison. And what that tells us is that there's something specific going on when it comes to alcohol-related outcomes, and that alcohol-related outcomes contribute towards socioeconomic inequalities overall. And this in turn indicates that alcohol control policies may be a really effective way of addressing and reducing socioeconomic inequalities in health. Now, what we would like to understand when we look at this is, of course, are these high risks caused by higher levels of consumption in people with high levels of deprivation or in people with low socioeconomic status? Yeah, so is it just because people with a low socioeconomic status drink more or riskier patterns that we see these elevated mortality risks? And this is what I investigated in this second meta-analysis here. Each dot represents a finding from a study. And the question was, how much of the inequalities can we explain by accounting for differences in drinking patterns? And here on the y-axis, you can see the proportion of inequalities that can be explained. And the first takeaway from this graph is immediately that none of the studies explained more than 30% of the inequalities in alcohol-related mortality when accounting just for alcohol consumption. And the second takeaway message is, as we move along this axis here, I ordered the studies according to how they accounted for drinking. And these studies here, they just accounted for the average quantity consumed per week or per month. And increasingly here, the studies accounted for drinking patterns. And these studies here, they accounted for heavy episodic drinking. So the second takeaway message is that the drinking pattern matters a lot in generating the socioeconomic inequalities, and it should be kept in mind when we try to address socioeconomic inequalities via alcohol policies. That leads us to the second question of the talk. How can we reduce socioeconomic inequalities in alcohol attributable health burden? Now, the good news is that effective evidence-based alcohol policies exist. These are pricing and taxation regulations, regulation of availability, and scale up of screening and brief intervention. The bad news is that currently these are not sufficiently implemented in many countries. And another disadvantage is that we don't know very much yet about how they affect the different socioeconomic groups. Now, what we do know is that we need to pay close attention in their implementation to ensure that people with a low socioeconomic status also benefit from the implementation of these alcohol policies. One example here is screening and brief intervention. We have found that sometimes when scaling up screening and brief intervention, so screening for hazardous alcohol use, can increase socioeconomic inequalities due to the lower healthcare access for people with a low socioeconomic status. That means that we need to combine initiatives to scale up screening and brief intervention with initiatives to increase healthcare access for people with low socioeconomic status. And we have to ensure that such services or screening and brief intervention services are available across a broad range of healthcare services, including community healthcare centers or occupational healthcare. Another example where we have to take care with the implementation is when we reduce availability. And I believe that my colleague, Dr. Trangenstein, will a little bit address this topic further. One policy that we know or that has quite good evidence so far, or very encouraging evidence on reducing socioeconomic inequalities, is minimum unit pricing. And in minimum unit pricing, we set a minimum price below which a unit of alcohol cannot be sold. So we raise the floor price of the cheapest alcohol available in the market, and this alcohol in turn is known to be more likely to be consumed by heavy drinkers and by drinkers with a low socioeconomic status. So this is a really encouraging policy with some first evidence on reducing socioeconomic inequalities. However, again, the implementation is not very spread, and I only know about 15 countries that have currently implemented some sort of minimum pricing policy. Furthermore, we should keep in mind that the differences in drinking patterns alone are only half of the story, right? There may also be an increased vulnerability for people with low socioeconomic status that puts them at greater risk of experiencing health outcomes, negative health outcomes. So for a comprehensive policy approach, we need to combine alcohol policies with upstream policies that address inequities in the root social determinants that give rise to the socioeconomic inequalities in the first place. That means that we have to improve the conditions in which people are born, live, work, and age in the long run. And such upstream or cross-sectoral policies should include policies for social protection, universal healthcare coverage, and raising levels of education and skills. Overall, we should promote a health in all policies approach where we evaluate and account for the health outcomes of all sorts of policies for different socioeconomic groups. Now, that leads me to my three key takeaway messages. First of all, alcohol attributable burden makes an important contribution to growing health inequalities globally. Second, cost-effective alcohol policies exist, but they are not sufficiently implemented currently, and we don't know enough about their effects on different socioeconomic groups. And third, Along with the implementation of our evidence-based alcohol policies, we need to address the upstream root causes of socioeconomic inequalities. Thank you.
I am honored to be here today to talk to you about alcohol outlets, particularly those in disinvested neighborhoods and how they both reflect and reinforce inequality. And so first, we should define alcohol outlet density, which is essentially the concentration of stores that sell alcohol, which are alcohol outlets, and the distance between them. And there's a wealth of literature showing that places with higher alcohol outlet density tend to see higher levels of harms. And these harms include both alcohol consumption, underage drinking, and then also alcohol-related harms. So things like drink driving, suicide, violent crime, and sexually transmitted infections. And this literature is large enough that we now have 3 systematic reviews documenting these associations. These findings have been replicated in countries across the world, and these countries on the map are not intended to be exhaustive, but rather just illustrate the diversity of settings in which these studies have been done. And outside the US, Australia and England have really been critical to this process. And research in Spain confirms why it's important to continue to build the research internationally. So one thing we know, and Dr. Probst's presentation confirmed this, is the same amount of alcohol in a less resourced community will do more damage than it would in a more resourced one. And this has nothing to do with the people who live there, but more with there's nothing to catch or mitigate problems once they manifest. And we also know that disinvested or deprived neighborhoods have more alcohol outlets than their fair share. And we just established that alcohol outlet density is associated with higher consumption and more harms. And so this is one reason why alcohol outlet density likely contributes to health disparities. So these data are from Scotland, and there they've found that deprived areas have 40% more outlets than areas that are more resourced. And this matters because Scottish neighborhoods with the most outlets have twice the alcohol-related death rates than those with the fewest outlets. So researchers in Scotland, the US, and I'm sure other places are beginning to question whether the inequitable distribution of outlets is shaped by both current and historical policies that have concentrated the power, wealth, and resources in some communities and left others behind. And the specific policies that played a role in this will differ both by country and locality. This is a brief case study of this kind of work from the US. The goal of this research was to examine whether unjust housing policies were associated with the locations of present-day alcohol outlet clusters. And I'm going to talk most in depth about something called redlining, which I'll discuss in a moment on the next slide. But I want to acknowledge research that Rick Sadler is doing that expands this work to also talk about gentrification and white flight. My research was in Baltimore, Maryland, but researchers at Pyre also did this similar work in the San Francisco Bay Area, which if you're familiar with the US, you know is a very different setting. All right, this is a 30-second overview of redlining. In the 1930s, the Homeowners Loan Corporation sent raters across the United States to classify neighborhoods according to how worthy they were to receive loans to buy homes. And the metric they used to do this was the racial mix of the neighborhoods. The neighborhoods that were the whitest got the best ratings and were shown in green on their maps, and they got the most loans. And the neighborhoods that had the most people of color living there were rated the most hazardous, got the fewest loans, and were shown in red on their maps, hence the term redlining. So these are maps of Baltimore showing the association between a history of redlining and present day alcohol outlet clusters shown in bold borders. In our statistical models, the history of redlining was the most robust predictor of where alcohol outlets clustered 8 decades later. It increased the odds of a census block group being located in a cluster nearly 8 times. And this is essential because when outlets pack together tightly in a cluster, it's the most harmful way that outlets can distribute. All right, I want to take just 1 second to reorient ourselves. We talked first about alcohol outlet density and how it was related to harms, particularly how the inequitable distribution of them may play a role in disparities. We then went back in time to talk about how historically unjust policies may cause that or may contribute to the inequitable distribution. And now we're going to jump forward in time to discuss how the harms that happen right around outlets, things like violence and loitering, drug sales, can deter more pro-social businesses from moving in to revitalize and invest in neighborhoods where there's high alcohol outlet density. So in these neighborhoods, you have things like public arrests, drunken loitering, activists who need to cart off intoxicated people, police who forcibly remove patrons, patrons who fall through the roof, and injuries. So you might be wondering if all is hopeless. And the answer is no. But moving forward in an equitable way requires intentionality. And in particular, who has a seat at the table when decisions are made matters. I put this flowchart here not with the intention of you reading it, but just to show that the decision-making process can be really technical and complicated. And this can lead decision makers and regulators to become captive audiences and can exclude community members in decision-making processes. This is unfortunate because community members and those who bear the brunt of harms from outlets have the most information about how these outlets operate on a day-to-day basis most of the time. In particular, they also can help decision makers make better decisions by understanding some of those unanticipated risks their communities and neighborhoods may face from policy solutions. That's why it's the best practice to write community members in from the beginning of the decision-making process. And this is not just community leaders, but community members. And so you might be wondering, what can we do? All of us, regardless of what hat we wear, should be mindful of how we generate, use, and report on data about inequitable issues. It's important to try and use an asset-based rather than a deficit-based frame, and be thoughtful about how we report on these data to avoid stigmatizing neighborhoods by repeatedly referring to them as high poverty or crime-ridden, or stigmatizing subpopulations by suggesting people who live in historically disinvested or deprived neighborhoods are responsible for the harms that may have resulted from historical policies. Thank you very much.
Thank you, Pamela. And I appreciate very much these two first presentations because they put us a little bit in a larger perspective. We started with a problem related to alcohol, but the speakers clearly showed that these associations need to be interpreted also in terms of their causal path and their root causes that are linked to determinants, not necessarily to the alcohol consumption per se. So I want to both of you, Pamela and Charlotte, if I could, before we move to the other panelists, put a quick question, because both of you mentioned data related to countries in the Northern Hemisphere. So, but you also mentioned that you are fully aware and you did reviews related to other countries. How these conclusions will apply in settings of low-income countries? Do we have similarities? What lessons? What is needed from the evidence perspective to bring to the table in order for us to be more comprehensive in terms of the settings in which we can apply these recommendations that you have put forward?
Yeah, I can go first. So in all of, I've done a number of systematic reviews and meta-analyses, and in all of these, I identified almost exclusively studies from high-income countries. And I think the main reason for that is that the data that is required, which is survey data linked to mortality data and cause-specific, quite detailed mortality outcomes, is currently often not yet available in low and middle income countries. However, I've done research together with Dr. Charles Perry, who's going to talk later, on socioeconomic inequalities and alcohol attributable health burden in South Africa, and we found the same picture with vast socioeconomic inequalities in the outcomes. I think with regard to the policy playing field, I would expect that the same general rules apply, but maybe the landscape is a bit different, because being with having a low socioeconomic status, what that means differs, of course, from one context to the other. And then also we may have a higher proportion of unrecorded alcohol and different distribution patterns of alcohol that we have to account for in our alcohol policy strategies.
I think one thing we need, I also agree, most of the studies are from high-income countries, and that's really a big limitation right now. We have some great data out of Brazil, and also some data from South Africa as well. But one of the big limitations that we face, particularly with alcohol outlet density in low and lower middle income countries, is that so few of them regulate it, and so few of them license. And that is really a limitation in terms of understanding where the outlets even are to do the research. And so I know Richard Matsopoulos has done some really nice research in South Africa, sending researchers out to identify where the outlets are, and then trying to, enumerate a protocol for that. And we need creative researchers to go out there and innovate to try and build so that we can understand, because it's likely those illegal outlets that are causing the most burdens to families and communities around them.
The question I have, Pamela, is for you. And here it says from Leslie, it says regarding the density in many low middle income countries, the state plays a more direct role in relying or even promoting small businesses. It's mainly poor people who needs this kind of livelihood support. So that exacerbates the spatial injustice. I think so how do you see, and I think Leslie, it's a more complex question, but I will stop it here, and we will just for Leslie and the other participants to know. This is something that we will develop also. We are already planning to develop in more details, and especially the issues related to gender and how sometimes these type of vendors are women that sustain their homes, their households with this income. But in the meantime, a quick reflection from Pamela before we move to the next speaker.
Yeah, I mean, I think that overall there's so much margin to move forward and build and really help communities without moving policy forward with alcohol outlet density. There's so many harms, diverse harms that will vary across localities, and there's so many ways that communities can play a role in this policies, and I really look forward to seeing how different countries move these policies forward.
I want to start by acknowledging the traditional owners of the land that we're meeting on today, and that's the Ngunnawal people here in Canberra in Australia, and to pay my respect to elders past, present and emerging. And I want to introduce you to Auntie Helen. So this is Auntie Helen. She's 74. She's an absolute legend, and I feel very grateful to know her. Auntie Helen is from the community of Bagot. The community of Bagot experiences high levels of alcohol harm, as does Darwin and the greater region of Darwin and the Northern Territory in Australia. So in the areas around where Helen lives, 2/3 of family violence cases reported to police involve alcohol. And so Auntie Helen and her community have decided to be a dry community, which means that there's no alcohol in their community. And the Northern Territory government in Australia has acknowledged that the harms are so great that they've introduced a moratorium on new liquor licenses. So this points to what was being said about availability. They've said no more liquor licenses are allowed. But that didn't stop Woolworths, which is one of the biggest companies in Australia and controls half of the alcohol retail market in Australia, from trying to build one of the biggest bottle shops in the country near Auntie Helen's community and in the greater Darwin region. So this bottle shop, if it went ahead, would be 1,800 square metres, and that's more than 19,000 feet. It would be one of the biggest bottle shops in the country, and it would increase the availability of alcohol significantly in that area. A question you might be asking is, how can this corporation progress this, given that there's a moratorium in place? Well, what they did was they used an existing liquor license, which was 4.5 kilometres away and 43 times smaller in terms of the volume that it would sell, and they transferred this license to get around the moratorium. And so what happened then was the community turned around, and community organisations, civil society organisations, and they contested this liquor licence through the Independent Liquor Licence Committee in the Northern Territory. And the Independent Liquor Licence Commission did what the evidence told them to do and what the community told them to do, which was reject the store. And this should have been the end of this story that went on for 5 years and is only just wrapping up now. But what happened was this corporation decided to continue to pursue this store. They appealed using different courts to try and get this store up. They lobbied the government to change the law not once but 3 times to make this store possible. They applied lots of pressure to decision makers. They ran a public relations campaign in the media talking about how great this store would be for the community, how great it would be for jobs, how great it would be for development. And what happened was this continued the battle then for almost 5 years. So what did we do as an organisation that was working alongside many other organisations in the country to support Helen to reject this store or oppose this store? We looked at the different possible pathways to stop this store from going ahead. I think at this point, it's really important to say these inequalities don't just happen. These stores don't pop up because they pop up. These are decisions made by people in boardrooms to take advantage of people in this way and to make money off this disadvantage. It's no surprise that these stores pop up in these sorts of communities, and it's no surprise that these products are targeted at people who might be drinking at the riskiest levels. It's done to increase profits to these corporations. So we looked at 4 different pathways to try and stop this store. The first was around legal opposition. And the thing we knew is that no matter how much we fought through the courts, Woolworths' pockets would always be much deeper than ours. And so they would continue to fight. So that wasn't something that we thought would stop the store. The second thing we looked at was government intervention. And because the government had already changed the law once at this point when we were assessing what was going on and we knew that they could possibly do it again, then we knew that it wasn't possible to change it through laws or through parliamentary processes. So we looked at 2 other options then, which is somehow stopping the development or trying to appeal to these directors who have a responsibility to their shareholders to not be causing harm, to not be hurting the reputation of the company, to try and stop progressing with this store. And so these were the 2 options that we really honed in on. And to do that, to speak to this corporation, to speak to these directors, then it wasn't going to be the CEO of an organization or a professor or a doctor who was going to speak to these directors. It had to be people on the ground. It had to be people who were directly affected. And so what we did was we stepped out of the way. We elevated the voices of people in the community who had these lived experiences so that they could have this national platform to talk about this issue. And as a result of Helen's story going national, a petition was launched by a young Aboriginal woman called Olivia, who lived on the other side of Australia. And that petition ended up amassing 155,000 signatures against this store. And we didn't have to say to these people, here's what's happening with outlet density and harm, and here's what the evidence says. And we knew the evidence said this, and so we knew it was important. What we did was we connected Helen, we connected the heads of the health services in these communities with everyone across Australia so they could hear directly what the impact of this store would be. Another way that we did that to keep that going beyond that media story was to engage, to work alongside Garawa, an Aboriginal creative agency who collected the stories of Sabina and Margaret and Auntie Helen and Peter and Samuel and John and shared those across social media. And I'm going to drop the links to these videos in the chat. And if you have a chance, I really encourage you to look at them, because there's nothing more than compelling than hearing from Auntie Helen talk about what happens in her community. To hear Sabina and Margaret say, money is not important, Woolworths. What's important is people's lives. And what happened when we were sharing these videos is that #ShameWoolies trended on multiple occasions. What we did was we followed every single critical point for that company, whether it was an AGM, whether it was them doing a press conference, whether it was them speaking at a parliamentary inquiry, and made sure that questions were asked about their decision to pursue this store. And so what happened in this circumstance was that the pressure was felt so much by this company that they engaged a lawyer to do an independent review. Now, we all normally know how these go, and there was reluctance to engage in this process. But actually what happened was this review was so damning that Woolworths pulled out of this store and surrendered the license and cancelled this license. And that review report hasn't been released yet, but it will be released in coming weeks. And that could have implications for liquor licensing and system change across the country into the future. So I guess the message that I wanted to leave with you is one from Auntie Helen when I was calling her and telling her that what had happened and that Woolworths had decided not to progress the store. I said, don't get too excited. These companies sometimes find other ways. They'll find a back door. And Auntie Helen said, if they find a back door, I'll be standing there waiting for them. And I think it's this activism by these communities. It's this passion to pursue change that really motivates us to continue to use the evidence that we have and that connection with community and our understanding of lived experience to create the change to reduce harms.
Hello, everyone. Yeah, thank you very much for the opportunity. I'm really touched by this story from Australia. It's beautiful, wonderful that we have some really strong resistance going on. I'm going to talk a little bit about what's going on in Brazil. And well, overall, news are not good about Brazil. I need to make that statement because, I mean, I think we're going through really, really challenging times. Well, just to a quick introduction of who we are. We are a coalition of organizations working on the promotion, health promotion through the control of the risk factors for non-communicable diseases. We worked as a coalition doing advocacy for policy change. Basically want to change the environment so that the environment makes it easier for people to make healthier choices. But we need to talk about Brazil. I mean, we are one of the champions, and I'm really not proud to say that as a Brazilian, but we are one of the world champions in terms of inequalities, which is also the subject that we are discussing here. So just to put it in perspective, 5 Brazilian men have the wealth of 50% of the Brazilian poorest population, which is about 100 million people. At the moment, like talking a little bit about the challenge we are facing with regards to the impact of the COVID pandemic, we have like about 20 million people that are starving in Brazil and over 100 million people that are in food insecurity situation. And what alcohol has to do with that? I mean, if we look at the concentration of power, 3 out of like the 5 of the rich Brazilians men, they are from the beer industry. So that's just to put in perspective what we face in terms of challenge when we try to do any type of regulation for or any alcohol policy issues. So we have like, and they are also like the major brewery worldwide, not only Brazil anymore with AB InBev. So it's a huge challenge in terms of economic power that it's obviously translated into political power. And this, I know this is in Portuguese, but I'll tell what it is. And in the COVID pandemic, the situation of inequality became even worse, and it's amazing, in a bad way, as obviously. But the super rich in Brazil, their fortune has increased by $34 billion during the pandemics. So the situation, it's not getting easier. And remember that out of the 5 richest ones, we're talking about the beer industry guys. And I'm coming to the smart affordability as a case. I mean, we could talk about hours about all the examples of things that are going in Brazil that reinforce the inequalities and promote alcohol consumption. But just to talk about the smart affordability issue, it's important to see who is behind some of the strategies also and what connections they have in terms of like the fiscal incentives that this industry receives in Brazil. This is the current CEO of Ambev in Brazil, and he's from a family that it's from the Brazilian Northeast. And they have his family, it's also one of the controllers of like the soda industry production and distribution, particularly in the Northeast. Why I'm saying that? Because in Brazil, in the Amazon region, we have the tax shelter, which gives lots of fiscal incentives and benefits, and the Brazilian beer industry is heavily benefited by that as well. And this Northeast strategy is deeply connected with the strategy to connect with like the local populations. This is a picture taken from the website of the government, one of the Northeast states. It's happening in several Brazilian states, but just to give this one as an example, the case of Maranhão, this is a picture with the one to the left. He's the governor of Maranhão. And because of the new branch that the new brand that they launched there, made with manioc, with the Brazilian manioc, with local produce and buying from local producers, they have just increased like the vulnerability of those groups, but obviously they receive lots of state level incentives as well, not only the federal benefits that they already have, but with the strategy of having these brands made out of the Brazilian produce, like manioc, they buy it from local groups and family farmers and so on. So that has also consequence when we think about food security policies. So it's not only about like beer, it's about using manioc for what you're using manioc instead for using this produce for feeding the population, right? And how this is covered with like this, they say that they generate that many jobs, but when you look at the amount of money that we receive in terms of incentives, it really doesn't pay. So this is, and of course, this is also linked with the war between the major beer producers. And this is a brand from Heineken, Brazil, that's kind of much, you see that it's more expensive than the newly launched smart affordability brands that's taking place now in 5 Brazilian states, always having dialogues with like the local culture and saying now, wow, this beer was born and created in this state because of this and this cultural characteristics. And that is valid for all the Brazilian states in which this is happening. And there is a connection, a direct connection, because we are talking about really some of the most vulnerable states in Brazil. Maranhão is one of the most poor and unequal states that we have in the country. So it is a really good example to talk about inequalities and the strategy to promote alcohol even cheaper. I was thinking about hearing about the presentation about the outlets. I think we have an additional challenge now with the COVID. It's that the Brazil, they have a strategy which is kind of a delivery platform, digital platform, that it's been really effective in deliver alcohol at much cheap prices in all communities and also low-income communities, no matter where the outlets so much are located, but they have a really effective way of distributing it. So, and it's a huge strategy. I just to bring to move towards the end, I think, what can we do about it, right? I'm not saying it's easy, but we are at the moment discussing a tax reform in Brazil. And this chart here shows some of the opinion from parliamentarians that we did together with other civil society organizations about several issues. And there is a strong support of higher taxations for unhealthy products, is the one to the left. 69%. This is a survey with parliamentarians. And for the prohibition also of subsidies of unhealthy products. And in terms of which products should have higher taxes, there is high acceptance for tobacco, 73%. For alcohol, it's good, 60%, and also for sugary beverages. So I think it's really important if we are, I mean, because we are in the middle of a crisis situation, and that's not only in Brazil, I mean, a health crisis, I think we really need to look into what's happening also as the impact of the COVID, because what we have seen now is that, I mean, we have so much knowledge and we have, however, the inequalities, they are increasing, they are not decreasing. And I totally agree with what was said before. It's about what choices we make in the decision-making process. And what we have seen so far, like also collecting some examples of the beer industry or the alcohol industry actions during the COVID pandemic, there's so much corporate social responsibility tactics going on. So they are increasing their capability of doing marketing their products. They are making their products cheaper. So they're making their products more available, more affordable, and more acceptable by the general population, and also the acceptance of the industry behind those products. I think we are in a situation when you talk about the risk factor for non-communicable diseases that you cannot separate the product from the corporations that are producing it and commercializing it really heavily. So we need to focus also on the commercial determinants of health. We need to have safeguards about conflict of interest where the decisions are made, the policy decisions are made, and we definitely need to end all subsidies and fiscal incentives, or else it will, we'll never really win that one from a public health perspective. And for that, I think we need to follow the financial flows. Where is the money going? What is the public money supporting at the end of the day? Or also be like a few health advocates promoting the impossible to achieve, because there's so much money going to support the strength and the economic power of those industries. Thank you.
Thank you, Paula. And I need to move now to another speaker, but I have Maristela Monteiro, who is Senior Advisor for Mental Health and Substance Abuse in the regional office in the Americas, who has raised her hand. Please, Maristela, go ahead.
Thank you. I like to, don't think I can turn on my video, but Paula always makes incredible presentations. Thank you very much. And the others that I didn't see from the beginning, but I saw them. My question to you is, you have to survey the parliamentarians. I know the majority of parliamentarians are supporting these measures. And then when it comes to voting, they may reverse. Have you tried to put names to who said yes to your survey and use that and said these people support, so to hold them more accountable for when a bill comes to Congress to pass? Thanks.
In that case, I mean, we haven't got to the stage of voting yet, but yes, definitely it's a good strategy. And we have done it like in the past regarding tobacco control issues and trying to expose who is doing what. But I mean, of course, the mechanisms in which like these bills are prevented from moving in the Congress, they are much more subtle or not really explicit. They say something in public because it resonates with public opinion, because when you talk about with the opinion polls, with the general population, there is really, really strong support for increased taxation. But there is a big gap in between what happens in real life and what people say. So but definitely that's a good strategy, Maristela. Thank you. We are trying to use that when we talk about the tax reform.
Thank you once again. Yeah, so Alcohol and Drug Information Center, Sri Lanka. So our approach, I can simply tell you like this, the deglamorize alcohol use and demystifying alcohol use. The reason for this is that the most of the people start using alcohol and continue using alcohol while knowing the harm. So just know the harm may not help, especially for young people, to reduce or to quit alcohol use, as because that the glamour of alcohol and the myths around alcohol in the communities actually continue and force them to drink alcohol. In our work, we do research, policy advocacy, and community intervention, but the community intervention is our real foundation. Based on the total population approach, it is because of the health promotion approach we follow. So we try our best to make changes in the communities as a whole, rather than changing the individual behavior. So actually, according to our experience, this works well, as because the human beings are social animals. And as a result of many years of working with young people, now we have young people in the country who counteract industry promotions, busting the myths in the communities, confront with the industry agents who promote alcohol, and change the norms established by the industry and some cultures. And actually they pressure politicians to get the effective policies. And at the same time, they expose politicians who are supporting to the industry. So, and the other important fact I want to share with you is that actually, rather than telling what will happen after drinking alcohol, we try our best to question alcohol itself. So the young people now reveal that alcohol is a dull chemical, it's a depressant, and drinking is a boring activity. However, the industry make it positive, beneficial, and attractive by their aggressive marketing and unethical promotions, even through cartoons and all, to very young people. And they buy politicians, they bribe policymakers, and they block the effective policies by many ways. In the picture here, it is in my local language, but the meaning of it is that whatever the brand you drink, it is alcohol, C2H5OH. And it's a depressant. And what makes you fun is not the alcohol, but the image. And here it is another example that this post and the poster, it says that whether you drink by a bottle or a can, this only you can do. I think you identify what he's doing in the picture. Another example is this. It says that no different in this year too. This is actually the New Year kind of message. The empty head forces you to drink. We are targeting here the people who are promoting alcohol among their peers. They are not paid by industry, but they are doing it by their own to promote alcohol to somebody else or to a group. So what we are doing here is that we are telling that only fools do that today. So this is exactly an advertisement of Lion Beer Sri Lanka, one of the popular brands. So the young people took the industry promotional poster and they changed it a bit. And the lioness is telling, you are getting weaker. And it says that alcohol causes sexual impotence. If not sure, ask your wife. So I think you can identify these kind of things, that what we are doing is that not really improving the knowledge of alcohol among young people and the population, but trying our best to destroy the image and using the colloquial language. And we are mostly addressing the feelings of people than the knowledge. And this is another example. This poster questioning, if I translated it, sounds like, is it pleasurable as you pretended to be? The reason is that most of the setting, honestly, that many people do not enjoy their alcohol usage, but they are pretending that they are enjoying as because it's a social norm. And they're actually uncomfortable most of the time, and they make a lot of difficulties, but they don't show it. This is another example that in the picture, he's our former finance minister who is very industry friendly. And once he made that statement that beer healthier than sweetness of drinks. So we made a huge campaign all over the country against his statement and his work. And finally, the kind of prestigious newspaper, very popular cartoonist came out of this cartoon. So that is also a kind of the social change that actually leads to media. And this is another example of the social media post, that it is about the parliamentarians who actually in favor of alcohol and tobacco companies. And here, this one actually came out just after reducing the beer tax. And you can understand that the most essential goods are actually unreachable, unaffordable. But beer, by making it a kind of tax reduction, is more reachable to poor people. So this is community groups. They plan activities, they implement, and not only that, actually they measure the impact of it. That depends on the kind of resources they can mobilize from the communities. They act their own voluntarily. So our one of the big campaign that we are doing is that actually changing the norm. So the slogan we use is that, who said alcohol is fun? We wanted to actually make it a kind of very kind of media, to get the media attraction. So what we did was, through young people, we lobby the modelers and the actors and actresses in the country. Because as we know that they are the people who promote alcohol for money. So as a result of the kind of strong lobbying by young people to the modelers and the kind of actors and actresses, finally we were able to do a kind of fashion show with all these people. And what is most important here is that none of the actors and actresses or the modelers actually charge a single cent for coming to this event. It was completely free of charge. They came. And not only that, actually they wear the t-shirts and the other kind of dress that actually shows a kind of prevention message to the public. And what we are trying to do our best is that we integrate alcohol prevention into the youth agenda in the country. So that can be a kind of cultural event, it can be a sports event or any other social event. So our strategy is make it alcohol prevention fun and simple both. So then only it will be attractive to young people. And our experience so far is that when young people engage in this kind of activities for alcohol prevention, challenging the ministers, parliamentarians, busting the myths, and actually challenging the industry for their glamorization of the product. So the young people actually immunize themselves to, to face the industry type of foreseeable type of promotions. So that is our experience. And if actually we are a scientific based organization, and the theories behind this model is social learning, classical conditioning, and expectations. So if you need some more information, you can log on to the website addict-srilanka.org and our Facebook page of ADDICT. Thank you very much.
So I'm going to be talking about alcohol in sub-Saharan Africa, as Juan Tello mentioned, going to be covering 4 issues: vulnerabilities, the drinking patterns and burden of disease from alcohol in sub-Saharan Africa. And then the main focus of my talk is challenges to charting a new way forward for alcohol policy in sub-Saharan Africa, and ending with a program for action. So talking about the vulnerabilities with regard to alcohol in sub-Saharan Africa, really there are a number of key points that need to be made. First, over time, we've seen increased consumption of commercially produced alcoholic beverages due to consolidation of recorded alcohol markets by multinational companies. And this has increased over years the availability of alcohol at varying prices. We've seen changes in the alcohol industry's advertising and marketing activities, including in Muslim countries. We've seen much more marketing now, internet marketing, billboards, and so forth. We've seen the introduction of new products, sachets, which are very cheap, selling spirits. We've seen larger and larger beers. In my own country, the most used beer is the quart beer, 750 milliliters, but there are now 1 liter beers and even 1.5 liter beers. And there's a link in most cases with the larger the size, the cheaper the product. And these beer containers can't be closed once they're opened. Also, many new types of alcoholic flavored beverages in the region, which are aimed at young people and females, which are less likely to be drinking alcohol than males. We've seen over the years, we've seen the dominance of alcohol companies in the production of alcohol, as opposed to traditional community-based small-scale female producers who used to use the harvest in summer to produce, in the long distant past, beer and other products which were used in celebrations and before people went into war and afterwards and so forth, to make alcohol much more available all the time. And we've heard about this too, the weak or non-existent national alcohol policies in many countries. We also have a situation where we have a high number of abstainers. In my own country, only 31% of adults reportedly are current consumers of alcohol. So a lot of people don't drink, which makes this area, sub-Saharan Africa, seen as a ready market for alcohol manufacturers, a youthful population. And we also have a situation of heavy episodic drinking. So where most of the population don't drink, a large proportion of those who do drink heavily. And I should go back to my earlier slide, which in fact just mentions to you that much of what I'm saying is coming from this article, which was published in Drug and Alcohol Review in March this year with several colleagues, Nea Moragele from South Africa and 2 colleagues from Nigeria. So what is the burden of disease and drinking patterns of alcohol in sub-Saharan Africa? Some key findings here, I've just listed them, and I think it's probably easier for me just to almost read them, go through them. Except in West Africa, more than 50% of the adult population are lifetime abstainers, especially females. In West Africa, it's less than that, but that certainly is an issue. It means that the area is ripe for increased penetration by the liquor industry. In most regions, both genders, current drinkers are a large minority. And we've seen a small increase in current drinkers in West Africa in the 2016 data. Adult per capita consumption, it varies across the region to 8.9 liters in Central Africa per drinker per year. to 25.1 liters in Southern Africa per drinker per year, with between about a fifth and just under 50% being unrecorded. Heavy episodic drinking, as I mentioned earlier, is a huge issue, and we define that as 60 grams of alcohol per drinker at least once in the past 30 days. The rate for heavy episodic drinking, for example, is 47% in Southern Africa and in the southern part of Sub-Saharan Africa, and 81%, it's substantially higher in Central Africa. So a huge issue there which needs to be addressed. When we're looking at the burden, in 2016 data, it's about 70 per 100,000 is the age standardized alcohol attributable deaths in the Afro region. So it's 70 per 100,000. And where is that burden distributed? Firstly, mostly deaths related to non-communicable diseases, then followed by communicable diseases, and then perinatal, maternal, and nutritional conditions, and then injuries. It varies somewhat in different parts of Sub-Saharan Africa. And it's higher than the global averages, that 670 per 100,000. And it's decreasing, though, that's good news, except in Central Africa. And I want to focus particularly now on my next two slides on two papers that have shown economic inequalities and the burden of disease in Sub-Saharan Africa. The first was briefly referred to by Dr. Probst in her discussion, answering of questions, and it's work from her PhD thesis, which looked at South African data, and particularly here we were looking at mortality data. And what it shows is the burden of alcohol in terms of mortality, firstly, is substantially greater for men than women, which we would expect. And then there's a gradient when you look at socioeconomic level, with for both males and females, a much higher burden of alcohol-related deaths in the lower and then followed by the middle income groups compared to the higher SES groups. So the burden is particularly faced by the poorer sectors of the population. And this particular study, in fact, showed that we have 172 approximately, with obviously a confidence interval around that, deaths per day from alcohol-related causes in South Africa. The second paper was by another PhD student who was supervised by Nadine Harker in my unit, which came out this year. The title was Assessing Intertemporal Socioeconomic Equalities in Alcohol Consumption in South Africa. And I just want to point out, this was now a prevalence study rather than the other one was a burden of disease study looking at deaths, alcohol-related deaths. And the results showed that current drinkers in South Africa were more concentrated amongst richer South Africans. However, binge drinkers were more concentrated amongst the poorer population. Secondly, for current drinkers, irrespective of sex, race, age, and urban living, socioeconomic inequality in alcohol consumption had reduced in time. In other words, there was a lesser indication that drinking was more evident amongst the wealthier between 2008 and 2014-15. So in terms of whether poorer people drink less than richer people, that is changing. So poorer people are starting to drink, move in the direction of the richer South Africans in terms of the proportion of those subgroups drinking. When we look at binge drinking, again, outside of the Asian, Indian, and rural categories, we also saw that inequality in binge drinking was reducing. But what does this mean? It meant that binge drinking is now slightly less evidenced amongst the poorer sectors of the population. It's also showing amongst the wealthier sections as well. So some of the challenges for moving ahead in terms of addressing alcohol policy in sub-Saharan Africa. We have the legacy of colonial past, which was paternalistic, and there were exploitative and socially controlling policies which exploited the alcohol use and controlled its use. And that complicates things because For example, in South Africa, we had the use of alcohol was controlled by municipal government, and it was used, some of the funding was used to oppress the population, and then the population created their own underground drinking establishments. So you have to deal with that. That makes it much more complex because of the previous policies. We have these, we call them shebeens in South Africa, which are largely mostly unregulated outlets, which often exist in residential areas, in houses, and they were initially a cultural expression of defiance against government policies. And it's hard to unpack that because it's seen as a sort of a cultural expression and a resistance to past inequities. And so much of the alcohol sold, for example, in South Africa, happens through unregulated outlets. And I believe that's certainly advantageous for the liquor industry, because then it's being sold in environments which don't have a large overhead. So it means that liquor can be sold quite cheaply, and it increases the profits for the major liquor companies. I'm not really sure what the advantage for the government is of continuing to allow that to occur. There are concerns about increasing excise taxes and minimum unit pricing as being regressive, and I think the research will show that that's not the case, but certainly it's something we have to address. There are large capacity gaps in Africa in terms of leadership, policy, ability to formulate alcohol policies, to monitor and evaluate policies, and so forth. I'll talk more about that in my last slide. We have industry interference in policy-making processes. I could talk at length about that. And in resisting implementation of evidence-based alcohol control measures. And in fact, one of the things that I believe needs to be given far more voice is that the business model for alcohol in sub-Saharan Africa, for large sectors of the liquor industry and liquor trade, depend on consumers drinking to intoxication. The business model wouldn't really be viable if everybody only drank, if drinkers only drank one glass every few days. They need to have the people drinking a large proportion of drinkers drinking heavily in order to make the profits they need. We also see industry aggressive marketing is often focused on the most vulnerable sectors of the population. And we even had a situation where the industry was exploiting poverty and hunger. And that picture on the right was the Beers for Africa campaign, which was a campaign to sell 8 different cans of beer from across different countries in the region, where a proportion of the profits would go to feed hungry students. And that was eventually pulled because of pressure. So it was interesting to hear the earlier example from Australia, where community pressure and civil society pressure changed industry practices. In this case, industry practices, but in that case, government policy. Well, it was an industry policy. Corporate social responsibility organizations are commonly used for indirect marketing. They put up to show that they're trying to deal with a problem, but in fact, it also is a form of undercover marketing. And they're used to influence existing policies to favor the drinks industry. And there's a good example in our paper about Nigerian breweries' support for education and environmental agencies. So finally, a program for action. How do we move forward from here? A recent review we did, published in 2019 on alcohol control measures, found that there's actually very little research done in developing low and middle income countries. And I think that's an area where we need more action broadly. But what's needed at a country level and a regional level? I think we need to facilitate alcohol policy development in countries in the region, particularly in areas where policy is lacking. We need to build capacity in countries to support the implementation of effective alcohol control measures. It's not only about having good policies, it's about seeing that they get implemented. We need to share lessons learned across countries about what works to reduce the harmful use of alcohol and industry interference. We have experiences, for example, in Uganda and Malawi of turning around the use of the availability of sachets, and maybe that can be shared with other countries so they can reverse that particular practice. We need to develop multinational and regional responses to issues that affect individual countries' ability to implement effective alcohol control measures in areas like taxation, international trade policies, cross-border and digital marketing, and also epidemiological surveillance, because some countries have capacity and others don't. And I think we need to share experience so that each country doesn't have to take the time to learn how to do these things, but can learn from successes. And I think, as I was talked about previously, we need to expose the dependency of large parts of the alcohol sector on heavy episodic drinking, especially among poorer sectors of the population. And I think we need to keep the liquor industry out of direct alcohol policy making processes. We've seen this happening in South Africa. And I think the role for the industry should be to comment on government policy and to put their own policies on the table, but not to have a seat directly at the table because of those conflicts of interests, which are so prevalent and which really need to be exposed. So with that, I'll stop. Thank you.
I'm going to talk about what we've learned from other industries that might be relevant to the alcohol industry. And I'm especially interested in understanding how the deeper characteristics of the global political and economic system affect the prospects for changing industry practices that contribute to harm. And I'm going to talk about these 5 lessons that I've identified from the variety of industries I've looked at, both the harmful commodities industries, but also other industries as well, including pharmaceutical, automobiles, and social media. I think the first lesson is we need to focus on practices as well as products. And in looking at some of the ways that the global corporations that promote unhealthy products work, these are the practices that I've found particularly important. One is monopoly concentration, the growing concentration in a handful of corporations in a multiple number of sectors. And that gives those few corporations much more power in comparison to governments and civil society. The second, and we've heard many of examples of that today, the tendency in this 21st century for large corporations to undermine democracy with campaign contributions, lobbying, what we call dark money here in the United States. We've seen in alcohol, but also in tobacco and pharmaceuticals and many others, the funding of scientific disinformation campaigns. And so it's become increasingly more difficult to develop fact-based policy because industries are working so hard to undermine that scientific information. Many industries, including alcohol, design products to be hyper appealing. And that makes it more difficult for people to resist these products. We've also seen, and tobacco is of course the prototypical example, that as high-income countries control marketing, distribution, pricing, these industries move to lower-income countries and to low-income populations in high-income countries. And we've also seen unscrupulous marketing of products, and we've heard many examples of that. I think a second lesson that I've learned from looking at other industries is we need to identify the characteristics of our political and economic system that encourage harmful business practices, those designed to increase profits and market share, and harmful political practices. And these include the increasing control of globalization. Globalization has been true for a very long time, but the largest corporations are shaping that globalization. We've seen increased power of the financial industry, and they're putting pressure on industries like food, like alcohol, to make decisions that are in their short-term financial interest, even when those decisions end up harming population health and promoting health inequities. We've seen ideological campaigns on individual responsibility. We've also seen a very concerted effort to change tax rules at the global level and the national level to make it easier to avoid taxes and to evade taxes. I've been very concerned about corporate control of science and technology. You know, Louis Pasteur says science belongs to all humanity, but increasingly science belongs to the corporations who can afford to obtain the patents. And we've also seen, especially in what some people call the neoliberal period, increasing deregulation promoted by industries like the alcohol and tobacco and food industry. Some people use the term neo-regulation, which I think is an interesting concept, that it's not that there's not regulation, it's that increasingly the regulation benefits the needs of the industry rather than of the population. A third lesson that I've learned from looking at other industries is the role of predatory marketing. Marketing of unhealthy products, products demonstrated to be unhealthy to vulnerable populations. And I believe that a really appropriate goal for all of us working in public health in these different commodities is to denormalize predatory marketing, to make it unacceptable, morally unacceptable, ethically unacceptable. And I think these webinars can play a really important role if we can begin to exchange strategies for how do you normalize predatory marketing and other unethical practices. As we saw in the example from Australia, we need to connect harmful practices to the everyday experience of those most harmed. We learned from the women's movement that the personal is political and the political is personal. And so in alcohol, we need to ask how our societies can shift responsibility for all the harms from alcohol onto the alcohol industry, to not allow them to shift these costs to consumers and taxpayers and governments. And if they were not able to, the economic term is externalize these costs, then their whole business strategy would fall apart. So that is another very important goal that we could be working together on, how to come up with concrete strategies to force industries of harmful products to re-internalize the costs that they're imposing on society. We talk a lot about evidence-based practice, but I think we need to put equal emphasis on practice-based evidence. From the presentations we've heard just now, around the world, there are hundreds of organizations and millions of people working to reduce the harm of industry using some of the strategies listed here. And we need to find ways to synthesize and bring together that practice-based evidence to turn it into a body of knowledge that can be used to counteract the harmful business and political practices of industries like alcohol. And I think each of these strategies here has had some successes, and we need to be working to synthesize those lessons and then to be able to apply them in multiple settings. So I think some of these key lessons are listed here. I've described each of them, and I look forward to hearing your questions and comments and to continuing these discussions in future webinars. Thank you very much.
So just, I mean, I think we cannot talk about alcohol consumption without talking about the Sustainable Development Goals and of course, you know, the impact that alcohol consumption has across these Sustainable Development Goals, including on, you know, on the inequalities. And of course, you know, many of the topics that were highlighted here, which, you know, are linked to hunger, to poverty, and to some of the situations that we see pretty much linked to the top, to some of the considerations that were also brought. We know that these are increasing. I mean, we know that COVID-19 has accentuated the inequalities, has even highlighted, the role of inequalities and how people in different socioeconomic status, are impacted differently. And we know, and Charlotte and all the presenters mentioned here, that alcohol harm affects differently the same. 1 liter affects differently, the different socioeconomic groups. And we have, also that the harm profile of alcohol is also different, because we know that people that have socioeconomic higher socioeconomic groups, that come from higher socioeconomic groups, will have more access to health services and will suffer, less. At least they will have more capacity to mitigate, as was also mentioned by one of the speakers. So I think there's a lot of examples that we heard here. What can we do and what was mentioned? Well, I think that all mentioned the importance of looking at alcohol through, having a life course approach, looking that reducing inequality starts, very early in life, and starts with the people where people are born, where they live, where they grow. And therefore, this life course approach is very important. Charlotte also mentioned the importance of having, the health in all policies. We need to really address alcohol consumption with the perspective that we need to have this, this dialogue, including pricing, availability, and other policies that need to be a part of a different narrative and a different dialogue, which means bringing all sectors together and having health as part of all the policies that are driven by governments. We also need the intersectoral and community action. This was also something that was highly mentioned. Governments can take the lead in bringing together the different sectors, and they should, because we need the different sectors to make a difference, but also we need the community. So community needs to be involved and needs to be part of defining many of the policies. And I go back to those discussions also on, the availability of outlets and the communities that are the victims in a way of, many of the policy decisions for which they were not consistently considered. Then also Charlotte mentioned the minimum unit pricing and the importance also of taxation, because we know that this reduces consumption, especially among the most vulnerable, the heaviest drinkers in poor income groups compared to the richer income groups. So therefore, this will be supporting the reduction of gap in health inequalities due to income. So what can be done right here, right now? I think that coming from the European region, I can say that in the European region, we're not doing well. Like Maristella, I think that, the different regions of WHO, we all share the same experience, which is, taxation, pricing policies are the least implemented. And we have also other areas where for sure we can do much more. There are differences between countries as well, and these differences are also important in terms of consumption and in terms of the patterns of drinking. One of the things that we know for sure, and was also highlighted here, is that, as we go and we look at taxation policies, we can see that there's been changes in countries, and you can see that in 1992, for example, we had already many countries in the Eastern European region, introducing new policies that made a major impact in terms of the mortality and life expectancy. This has been documented. So I would say, just to finalize, that we also need a shift, a paradigm shift on alcohol taxes. We know, and I think our last speaker was talking about some of the, how can I say, the ways that industry tactics are in a way I mean, common across the different products. And while for tobacco, it's very clear that tobacco taxes come as something which is about, it's a health tax, it's linked to a health tax. For tobacco, the concept is not the same. So tobacco taxes are seen as health taxes. Alcohol taxes are seen as, fiscal measures to increase, revenues from governments. So we need to change also the narrative in terms of taxation. Alcohol taxes should be a public health prerogative. They're very important. Other pricing policies are important, minimum unit pricing as well. And it can be tailored to the local harm profiles and to the needs. And we also know that this has been done successfully in countries in our region, but also we hope to see this being implemented in other regions. And then finally, pandemics, the COVID-19 pandemics has shown us that we have now the opportunity to implement these changes. We need to invest in public health. We need to invest in health systems. Health taxes on alcohol, tobacco, and sugar and sweetened beverages need to be discussed as a public health option. So these are my conclusions. Thank you very much for this opportunity, Juan, and I stop here.